everybody. We will get started. Welcome to our second grand rounds of the year and our second session in the senior grand rounds presentations. We have two excellent presentations for you today. Today's a cardiology day. Last week we had oncology. Today it's from our two budding cardiologists, not necessarily cardiology topics, but two soon-to-be cardiologists. We'll start off with Lauren East. She's from Suwanee, Georgia, then went to medical school at the University of Virginia, where she studied biomedical engineering, and that's where she first developed an interest in medical ethics, which leads into the topic of her talk today. She took a class by the renowned philosopher James Childress, those 4 biomedical ethical principles, and that interest continued to develop throughout college into medical school, where she was very involved in ethical committees there and into her research throughout residency. She's now finishing up her internal medicine residency here at WashU and is applying into cardiology. So please welcome Dr. Lauren East.
Well, thank you, Dr. Shreyas, for the very kind introduction. My name is Lauren East. I am going to be talking to you all today about a study that I have been working on with Dr. Malone and Dr. Emke from the Department of Pediatrics. It is still ongoing. It has been supported by the Washington University Teaching Physicians Pathway, as well as Mentors in Medicine. The study is titled Longitudinal Assessment of Personal Reflective Ability and Moral Reasoning Development in Medical Students, Impact of a New Curriculum. So disclosures and funding, we have no relevant financial or non-financial conflicts of interest to disclose. As I said, this study has been supported by the WUTIP program and Mentors in Medicine, and we greatly appreciate the support. So since this is the WUTIP lecture, we have to start with a session objective. By the end of this grand rounds lectures, participants will be able to, first and foremost, define moral reasoning, describe the current state of moral reasoning development during medical school, recognize the proposed connection between reflective ability and moral reasoning, and summarize the methodology and preliminary results of an ongoing medical education research project through the Department of Medicine. So first and foremost, defining moral reasoning. So moral reasoning is defined as the application of critical analysis to specific events to determine what is right or wrong and what people ought to do in a particular, usually ethical, moral situation. This process typically uses logic and moral theories, such as deontology, think Kant, or utilitarianism, think Mill, to consider specific situations or dilemmas. Kohlberg is one of the primary researchers and investigators in the field of moral reasoning. He proposed kind of 6 stages of moral reasoning development: pre-conventional, conventional morality, and post-conventional morality, and someone progresses as they go through the stages. Stage 1 is that somebody understands the world in terms of punishment and obedience, all the way to stage 6, and that somebody is able to reason through problems using universal ethical principles. So why do we think it's important for medical students to develop moral reasoning during undergraduate medical education? We believe that it is the responsibility as a physician to make ethical decisions, that being able to use moral reasoning allows for not only improved patient care, but deeper learning and therapeutic relationship building with patients. We also believe that with the rapidly changing medical field, that having a framework of moral reasoning to approach novel problems is also very important. We agree with Branch that good clinical practice cannot be separated from professional and ethical behavior that depends on moral maturity. So several medical education researchers have been interested in this topic dating back many years, both nationally as well as internationally. And unfortunately, During undergraduate medical training, moral reasoning development tends to either regress or actually stagnate. And this is interesting because in other graduate programs, other PhD programs, moral reasoning continues to develop, even when assessed using the same tools that we assess medical students with. So several theories have been proposed for why moral reasoning development stagnates or regresses. One of the more common theories is that during the clinical years, there is a hidden curriculum that kind of has undue influences that cannot be controlled for on medical students. Several medical education researchers support this theory. However, this is not something that we wanted to look at specifically because studies have shown that there is regression and stagnation even in the preclinical years before students are exposed to parts of this hidden curriculum. So we wanted to look at another theory that proposes that due to a correlation between reflective ability and moral reasoning and a regression in reflective ability throughout undergraduate medical training, that there is a subsequent stagnation or regression in moral reasoning development. And reflection in these studies has been defined as intentional review of one's actions or thoughts to inform continuous learning. It allows promotion of self-regulated learning and diagnostic ability, as well as opportunities for development in critical thinking and behavior. Reflection leads to greater understanding about self and situations, and thus informs future actions. So the new curriculum allows for the perfect opportunity to assess these things. The legacy curriculum was a traditional 2x2 curriculum with individual courses and was grade-based at the end of each course. There weren't many opportunities for structured reflection, and there were few academic advisory meetings shown by the stars here throughout the legacy curriculum to kind of reflect in professional formation, that sort of thing. The new Gateway curriculum is highly integrated with, as we all are aware of, early immersions into the clinical setting, seeing what we will actually be applying our knowledge to, perhaps encountering some of the moral dilemmas that we face on a day-to-day basis within medicine, as well as having many group coaching experiences throughout, shown here by the many yellow stars. These group coaching sessions support professional formation. The Gateway curriculum is also 3 phases and competency-based, not grade-based, so there's not that added stress on students. So our hypothesis is that increased opportunities for reflection in the new curriculum will lead to development in personal reflective ability and moral reasoning. Our purpose and aims are to describe the change in personal reflective ability and moral reasoning development in medical students over time within the new Gateway curriculum at the Washington University School of Medicine, and to compare those abilities in the students that complete the new curriculum versus those that completed the old curriculum. Aim 1 looks at reflective ability over time with longitudinal survey data. Aim 2 looks at moral reasoning development over time with longitudinal survey data. And then Aim 3 is just basically proving the same relationship between reflective ability and moral reasoning via linear model, regression model that other studies have shown. So our methods overview, we are using 2 different surveys, which I'll talk about in a minute, to assess personal reflective ability as well as moral reasoning development. These surveys both show evidence for validity in the medical student population. We are surveying 2 times across the old curriculum, post the preclinical time, and then at the end of medical school, and then surveying 4 times across the Gateway curriculum at the beginning of medical school, after phase 1, after phase 2, and then at the end of medical school. Our study population, our inclusion criteria were broad. We are looking at the legacy curriculum class of 2023 and the gateway curriculum class of 2024 and 2025. This is a longitudinal 5-year long study with the study timeline shown here. The study instruments that we are using for assessment, the one that we are using to assess moral reasoning is called the Defining Issues Test. This is the second version of this tool. It was developed by the University of Alabama Center for Ethical Development and has been very broadly used within medical education as well as moral reasoning development research. It has shown evidence for validity within the medical student population. It essentially has several passages that are presented to students, which we'll show an example of in a moment. And then it has questions based on each passage, both multiple choice questions and rating and ranking questions to address issues within the dilemma. These questions are meant to assess moral reasoning development level and then kind of stage students within the 6 stages of Kohlberg's moral development that we talked about at the beginning, from punishment, obedience, all the way to universal principles understanding. So this is just an example of one of the passages that the DIT2 presents to students. The example of the multiple choice question is shown here. There's many more different statements and questions that students are asked to rate and rank, but this is just a sample. We can go back to that at the end if anybody wasn't done looking. So we are using the Groningen Reflection Ability Scale to assess personal reflective ability. It was specifically developed for medical practice and education and has shown evidence for validity within the undergraduate medical population. It is a 23 different point Likert scale. A Likert scale means that you get a single point for strongly disagree all the way up to 5 points for strongly agree. There's 23 different statements that students are strongly disagreeing with to strongly agreeing with for a total of a possible 115 points. These are just a couple of the samples of statements that students are asked. So our analysis plan, we are linking and comparing survey scores across each curricula using a mixed model analysis. Our primary outcome is going to be interaction between scores and medical school class over time. We are using a linear regression to correlate personal reflective ability with moral reasoning development in our study. We think that this study's results will be significant, whether it shows development in moral reasoning and personal reflective ability across the new curriculum, or if it doesn't. If it does, that's great. That's the first time anything like this will be shown in the field of medical education, specifically with regards to moral reasoning development. If it does not, it allows us opportunities to see how we might be able to intervene, to see why some of the personal reflective opportunities aren't kind of creating the kind of impacts that we think they would have on students. And we're hoping to maybe do some cognitive interviewing and focus groups at the end of students' 4th year to further assess why that might be. So our initial GRAS response, the class of 2023, there were 11 respondents. They had an average GRAS score after their preclinical phases of 85.2. The class of 2024 have been surveyed twice, when they started medical school and then post phase 1. And then the class of 2025 has been surveyed at the start of medical school, and then there's pending data collection in this December. Our numbers, we have struggled some with recruitment, which we'll talk about, but if you'll notice, the class of 2025, we had many more respondents with about a 41% response rate within that class. So we're excited for our survey within December. So just comparing the scores from the class of 2024, the GRS scores, it's hard to make any conclusions on a longitudinal research study when we only have a few data points over time. But looking at individual scores here on the right, scores haven't really trended in one direction or the other significantly and kind of have clustered together, which is interesting. Looking at the scores as a whole and not individual scores, there's really no difference between first year and post phase 1 and no significant difference. The initial DIT-2 response, since this is a longitudinal study, our survey data is currently at the University of Alabama Center for the Study of Ethical Development undergoing scoring. It's kind of a complicated scoring process. This is just showing our response similar to the GRAS survey response. We've had many more respondents in the class of 2025 and are excited about our next data collection. So for this study, there have been many lessons learned. We had a poor initial response rate. In response to that, we added an incentive with some improvement. It's a $10 gift card. We've also had many partial responses that were excluded. The DIT scoring process in and of itself excludes unreliable responses. So anyone that was Christmas treeing or just going down and answering the same answer, which weren't many actually, but they will be excluded during the DIT scoring process. We've also noticed that when we pitch to classes prior to survey distribution and kind of explain why this study is important and what we're looking at, our response rate also goes up. Within medical students, I'm sure as many of you went to school here, there's a huge survey burden. So we actually reduced the number of surveys that were initially planned for the class of 2023. Our next steps in our study, we're waiting to get the data back from the University of Alabama Center for Ethical Development. We will continue to survey according to our study timeline throughout the next several years. We will need to adjust our final analysis for a smaller sample size than initially planned. And then we're discussing adding focus groups or cognitive interviewing at the end of medical school. Here are our references. And I'd like to thank the Washington University Teaching Physicians Pathway. It's been great in my professional formation, as well as Mentors in Medicine for supporting this project. I'd like to thank Dr. Jay Malone and Dr. Amanda Emke for being fabulous mentors, as well as Dr. Janice Hansen, Dr. Donna Jaffe from the Medical Education Research Unit, who have also reviewed and added to the study immensely. I'd like to thank the Washington University Teaching Physicians Program, as I already said, the internal medicine chiefs. Really appreciate the opportunity to present today and appreciate all your openness and support so far this year. As well as Dr. Cal and Dr. Costco for being fabulous mentors. Thank you. Do you have any questions? All together at the end. Okay, just kidding.
I'll be back. That was my mistake. So thank you, Lauren. We'll have time for questions after Shreyas' talk as well. We can do questions on both talks. So Dr. Shreyas Venkataraman originally hails from Dubai in the United Arab Emirates. He then went to medical school at the Pondicherry Institute of Medical Sciences in India before heading over to the Mayo Clinic for a research fellowship in cardiology, where he studied the OSA risk of arrhythmia in hypertrophic cardiomyopathy. He's now finishing his internal medicine residency here at WashU and is also applying to cardiology. So please welcome Shreyas.
Can everybody hear me in the back? All All right, welcome to Grand Rounds, everyone. Now, I'm going to be talking about coronary calcium testing, mainly because there's been a lot of evidence that's come about in the recent past in this space, and I feel like it actively affects our practices and in a positive way. That's why I decided to talk about this topic. So keeping in Grand Rounds tradition, let's start off with a clinical case. We have a 52-year-old man who comes to your clinic for a preventive visit as an IOV. No past medical history, says that he exercises regularly, but when you ask his family history, it tells you that his dad had an MI at the age of 49. To define his cardiovascular risk, we get a lipid panel, and he comes back in a week's time and tells you, and you tell him rather that his ASCVD risk is 6.8%. Now, what does that mean to him? He's kind of mulling over it. You're kind of falling over, not really understanding what the number means because it's an intermediate risk. And when you are talking, he takes out his phone and hands you this article on the New York Times and tells you, should we just get a scan? And in the recent past, a lot of articles have popped up in popular media talking about the calcium risk score. Not just this one right here. There have been multiple other ones in the recent past. And the impetus falls on us to learn about this topic because of all the information that's out there, good information that's out there. And with the good comes the bad, and the algorithm gods don't spare us from the bad. So as you can see, a quick search yields all of this. And people are really using the CAC score as a scapegoat to push their own narratives. Here you can see the vegan pushing his narrative with the coronary calcium score. And in the same page, you have another person pushing the animal-based diet with the coronary calcium score. And of course, you have a vitamin pusher saying it dissolves calcium. So right here. So in our time together, my objectives are, I'll briefly review the history and background of risk stratification, understand what has happened in the past 25 odd years. Why CAC testing? Why is it more relevant now than it was a decade or two ago? Should we reimagine cardiac risk stratification? Who should get cardiac CAC testing? And therapy decisions we can make based on coronary calcium testing. So let's turn back the clock about 25 odd years and go to a town in Massachusetts. It's a small little town, and a work of genius was happening there because this was the first time that a group of people were putting together risk factors and hoping to come out with a number that could potentially allow us to communicate risk better. But in the last 25 years, things have changed. And for its time, it really was a trendsetter. It really changed things because nobody had done this before. Nobody had really come up with a number to really quantify risk before these group of researchers right here. And, in the last 25 years, a lot has changed, unfortunately. The biggest downsides to the score itself is that it was a relatively homogeneous population, really dissimilar to the population that we treat today. In many ways, mainly because it was mainly Caucasian, mainly had a lot of men, not too many women. Their activity levels were different, their diets were different, a lot more smokers back in the day. And that's why this test doesn't really stand up, even not just now, even, if you go back 10 years. And that's why multiple researchers tried to rehash this risk score, come up with better risk scores based on new cohorts. In 2001, the ATP3 risk stratifier was published. This used the Framingham risk cohort, but used better models. Because it used the same cohort, it didn't really match up, and it performed very similarly to the Framingham risk score. In 2007, the Q risk score tried to address the disparities and the lack of diversity within the Framingham risk score by adding more women, by adding people of multiple races, and also fell short. The Reynolds score tried to address the lack of effectiveness by adding more women to their cohorts, and that fell short too. And finally, in 2013, the ASCVD risk score that we use today was published by the AHA-ACC consortium. And this addressed all of the issues that the previous scores could not, mainly by including multiple cohorts. It was a large group of people from multiple backgrounds. And as you can see here, it included people from multiple races, multiple socioeconomic strata, and it included a lot more women. And the important thing is that it did this by including people from multiple studies, but it also included the Framingham cohort, which was the original cohort, which goes to show how preeminent the original Framingham cohort was. And another thing that is significant is that it included stroke and TIA as endpoints too, mainly because this was not an endpoint in the previous risk scores. And now it is obvious to us that this is a cardiovascular endpoint, but back then it was not included in the risk score, and now it is included because of this group right here. And unfortunately, this had shortcomings too, and we'll talk about that in a little more detail now. So this group in 2003 hoped to understand how this stratifier really performed. And as you can see here, in a group of individuals with their first episode of MI, 72%, nearly a 3/4 of the group was quantified as low risk. Now imagine that you're being told you're low risk, and in the subsequent few years you have an MI. This means that the score is clearly not doing its job. Now, it's not just this, it's also overestimating risk. As you can see here, in this study from 2015, they saw that the observed events, when compared to the predicted number of events, was nearly 2.5 times lower, meaning that it was overestimating risk massively. And we are clearly not the best at predicting risk like Kevin here. And so, what else can we do? Are we stuck with the ASCVD score? Are we going to iterate with other scores by including multiple other risk factors that we already know? Or is there a more out-of-box approach that we can use? And this is where I introduce the coronary calcium test. So, pathophysiologically, it makes sense because before the index event happens, you can see that calcium starts forming within the arteries much before, because of the oxidative stress and the inflammatory milieu that exists within these arteries. And our job is essentially to find out who has calcium and understand why they have calcium and intervene on this calcium before this index event happens and the patient suffers from an MI. And we do this pretty effectively, actually. So we use a multi-detector CT that we use from all the other tests. It is quick because it takes only 15 minutes. It's effective because we get good images of the heart, and it is relatively inexpensive. But a major disclaimer is that it is not covered by insurance. So we have patients come into the scanner, have EKG leads placed on them. This is mainly to gate the scans in a way that we get better images of the heart by gating it with the EKGs that we get. And after we get images, we see if there's calcium within their hearts or if there isn't any calcium within the hearts of our patients. Multiply the amount of calcium with the plaque area and come up with something called the Agatston score, which can range anywhere between 0 and to the thousands. And the biggest concern that you'll have is, Shreyas, what about all the radiation that we're exposing our patients to unnecessarily in the primary care setting? Well, it does expose our patients to radiation, 1 millisievert, but in comparison, it is not much. The CT abdomen pelvis exposes our patients to nearly 10 millisieverts of radiation. The CT head, which we do pretty regularly in the ED, subjects them to 2 millisieverts of radiation. And the mammogram, which we do every 2 years on our patients, subjects them to 0.8 millisieverts. in comparison, one ain't all that bad, especially if you're doing it only once. And that's why I feel that it is quick, safe, and effective. It's a quick, safe, and effective test. And the next question you'll ask me is, well, there are so many other tests. Why would I start using the coronary calcium score if I have all of these other tests that I already have available under my armamentarium? So people have this question too, and they try to solve it by understanding how it compared to the other tests that we have available. So as you can see here, they took the Framingham risk score, which was because it was done in 2012, as the baseline, and they compared it to multiple other modalities: carotid internal medial thickness, CRP, family history, ankle brachial index. And the coronary calcium score vastly outperforms all the other possible modalities that we have available. And this is why I feel the calcium test is very powerful. And even a more recent study done in 2016 showed something very similar, where if we consider the dotted black line to be a test which offers no real value, and the green line to be the coronary calcium test, and everything in between to be all the other modalities we could add to our ASCVD risk score, it far outperforms any other test that we have that we can deploy. And that's what the authors concluded too. They thought that a CAC score of 0 is the strongest negative risk factor for the development of ASCVD. So what they're expounding is that we reimagine risk stratification based on this data. Now, why do they say that? So the classical school of thought is that we have all of these risk factors: smoking, hypercholesterolemia, elevated blood pressures. We put them together, we come up with a number, and we base therapy decisions based on this one number. Now, what the new school of thought suggests is that instead of doing this alone, we think about risk as more of a grayscale, being on a spectrum. And really, instead of using primary index positive events to move people from one category to the next, meaning primary to secondary or secondary to tertiary, which by then it's too late is what they're saying. We should act on patients before they have an event and not after. And what the coronary calcium score does is it gives us more nuanced information to de-risk patients. Now, what do I mean by that? So now let's say we come up with a number with the ASCVD risk score right here. By adding the calcium test and getting a certain number, in this case 0, we're able to de-risk patients and tell them pretty confidently that their risk of adverse cardiac events is low. And that does offer some closure to our patients. So let's come back to our case. And this is Google for middle-aged healthy man. So ACVD is 6.8%. So where do we go from here? He asks us if we should do a coronary calcium test. And this is what the data suggests. So if you can see that if their risk is less than 5%, they don't benefit from a statin. And adding a calcium test doesn't really change things too much, going from 0 to non-zero. The same holds true with an ASCVD risk score of more than 20, where adding a calcium test does not really change the event rate as much. Where we have value is right here, with an ASCVD risk score between 5 and 7.5% and 7.5 and 20%, what is classified as intermediate risk. Mainly because adding a calcium score to these groups, they're really changing the event rate pretty significantly, as you can see here. So going from a 0 to a non-zero number essentially triples their risk, even with one scan that took 15 minutes. And the same holds true with the 7.5 to 20% group, where by adding the coronary calcium score, we're essentially doubling their risk. And that is where the value lies. And this is what the authors concluded too. If they are intermediate risk and they do have a calcium score of 0, we can pretty confidently tell them that you fall under the less than 5% category, even though the number suggests that you might be at a slightly higher risk. And essentially tell them that you can wait to be started on statins. And that's what the current guidelines recommend too. What it suggests is that we can use ASCVD risk scores. This is in the 2018 blood cholesterol guidelines, which recommended that the CAC score of 0 indicates a low ASCVD risk for the subsequent 10 years. It didn't give any definitive recommendations other than this right here, but the primary prevention guidelines did it did show have this graph in there where if you do have a calcium score of 0, it recommended that the patient not be started on a statin or any drug therapy. And this is also reflected in the primary prevention for cardiovascular disease guidelines from 2019, where if a patient has a risk score between 5 and 20%, what they recommend is that if the risk decision is uncertain, as in these groups right here, consider measuring a calcium score and determine if they would indeed not benefit from therapy. So coming to therapy decisions we can make based on calcium scores. So we do give statins. We do give statins to most people, even when we're on the fence. But imagine this. This is a drug that they have to take all their lives. Given the history of the drug, there is a lot of information out there, good and bad, suggesting that this can cause myalgia and all the other myriad of side effects that statins supposedly cause. So I think it is in our patients' best interest to understand if they actually benefit from a statin. So actually, Dr. Mitchell from WashU and my mentor actually did this study where they saw that if a patient has a calcium score of more than 100, their number needed to treat is pretty low. You just need to treat 12 people to affect one person. While as the calcium score drops below 100, you can see that their number needed to treat increases markedly to 100. And as the calcium score drops to 0, you can see that it is not effective. And this is powerful. So what the study shows us is that if the calcium score is 0, statins are not effective. And in a patient who is not really interested in starting a statin, I think this offers scientific evidence that they needn't be started on statin unless they fall in one of those two groups, or rather have a non-zero calcium score. Now let's talk about aspirin. So in the past few years, we have seen a lot of evidence come out in the biggest of journals suggesting that aspirin might not be the best for primary prevention. Does the calcium score change things? So I know it's a bit of a busy graph, but I will walk you through it. So let's consider the red line to be the number needed to harm and the colored bars to be the number needed to treat. Our goal is to have a number needed to treat lower than the number needed to harm. And you can see that regardless of ASCVD risk, patients with a low calcium score do not benefit from aspirin. Patients from an intermediate calcium score also do not benefit from a statin. But patients with a score more than 100, as you can see here, do benefit from a statin. So there is a little bit of a disclaimer to the new evidence that's come out based on this study that if their calcium is indeed more than 100, the benefits of starting aspirin far outweigh the risks of bleeding, and that's what this study suggests. And based on what I've told you, I think this hashtag came to be called the power of 0. Now, what the people who worked in the space tried to achieve was increased utilization of the calcium score because of the results I've just discussed. And what they suggested was that the coronary calcium score is the most powerful predictor of coronary events in asymptomatic patients. And this is a sweeping statement. And they said, if you have a score of 0, you will not have any events. And that kind of insurance is dangerous, and those kind of sweeping statements will always have outliers, which is why there's been a lot of back and forth within the group about making sweeping statements like these. I think for us, we have to think about having a score of 0 as adding value, but let's not consider it to be something that gives us a definitive, absolute decision, and just adds to the variables we can use for making better decisions. So now let's say our patient has a score of 0, and he asks you next, because of the MI his father had, he asks you, wait, do I need to get retested? And this is what these researchers tried to answer. They found out that having a calcium score of 0 actually gives portends an event rate of 0.7%. But as they go from 0 to non-zero, the event rate shoots up to 5.7%, while if their calcium score continues to remain 0, the event rate is statistically non-significant at 1.8. So it is important that we rescan folks, and the timing of rescanning is based on what their initial ASCVD risk is. Now they try to kind of determine the number needed to scan. Think with the number needed to scan being the number of people needed to scan for yielding one positive test, going from 0 to non-zero. And as you can see here, their risk is low. A person goes from 0 to non-zero anywhere between 4 to 7 years. If it's intermediate, it takes 3 to 5 years. And if it's more than 20%, in which case they should have been started on a statin, but let's say they decided against being started on a statin, we have to rescan them in 2 to 4 years. Now, why is calcium important in this case? For many patients, seeing is believing. For many patients, the act of really seeing something wrong with their heart, seeing something as dramatic as calcium within their heart, can essentially be the inspiration and motivation that's needed for them to be started on a medication like a statin, given that being on a drug all your life can be harrowing. And I think this is what I'm trying to communicate here. So to conclude, the ASCVD risk score very obviously has its shortcomings, regardless of how far it's come in the last 25 odd years. And the CAC offers an inexpensive, quick, and effective test to further substratify patients in the intermediate risk group. And based on what we see on the CAC test, we can decide who needs to be started on a statin and who does not. And a CAC of 0 is powerful. It is powerful and does give our patients closure when we tell them, your risk of ASCVD events is low. So future directions, this is still a nascent space. We do need patient-centered RCTs. All of the data is, many of it is retrospective. We do not have RCTs. Unfortunately, like I said, insurance coverage is still an issue. It can cost anywhere between $100 to $300 out of pocket. Many patients choose to get it done, but many patients cannot afford to do it. And this is something that we'll need to address as a group, I guess. Its role in high-risk cohorts is still uncertain. We still don't know how useful it is in familial hypercholesterolemia. And my research has been to further substratify patients who have had coronary calcium testing by using a carotid intermedial thickness. So there's a group within the 5 to 7.5% group, which essentially still has a low calcium score, but has a non-zero risk profile. And our hope is to understand if a carotid intermedial thickness test will help in substratifying this. So I would like to thank Dr. Kachi, Dr. Mitchell, and Dr. Dow for very patiently listening to all of my tropes while I was practicing. Dr. Costco, Dr. Gage, and Dr. Frazier, the chief residents who also helped with making the presentation a little better. my co-residents for being here, the Mentors in Medicine and C-Star program for sponsoring and supporting my research and the IM residency. Thank you.
So if anyone has any questions for either Dr. Venkataraman or Dr. East, please feel free to ask.
Thanks. Hi. Thank you, Shreyas. I enjoyed your presentation. I agree that CAC is very useful in clinic. We say if you have a CAC zero, you don't get to live forever, but it does have predicted risk. So that's a nice rule of thumb. I echo your call for a randomized trial. Phil Greenland proposes to the NHLBI about 5 years ago. It's estimated to be about $100 million, which NHLBI balked at. But we do spend about $700 billion on cardiovascular disease every year. So it seemed like a good pitch, but alas, it didn't work. I would emphasize cardiovascular disease is a multiple risk factor condition, therefore multiple risk factors need to be addressed. Blood pressure, for example, is elevated in the patient. Thinking about lipoprotein A as a risk enhancer. So these types of patients, family history, blood pressure is elevated. Thinking about not just using multivariable risk prediction for statin initiation, but overall comprehensive preventive care. So trying to think about that, we developed a longitudinal risk calculator for Medicare that's being tested in a large randomized trial. Because if you think about other risk models like financial risk, it's not just one point in time and let the clock go. It's constantly updating that risk. It's challenging to communicate with patients in terms of limited numeracy, for example. And risk for all of us is going up, right? And just every day we get a little higher risk to get closer to developing atherosclerosis, unfortunately. So kudos to you on your work. Just wanted to reiterate, the need for some of these additional data points. But yeah, CAC is a great test. I find it very useful. Thank you.
Teresa, I have a question for you. So my mom just had this done like a couple of days ago, and it was like $100 out of pocket. How far away do you think like the insurance coverage is for this? Because I think, especially in the like a lot of the patients have Medicaid or Medicare or are uninsured, and $100 to $300 is certainly cost prohibitive for a lot of those patients that can't even potentially afford a statin, for example. So how far away do you think that will be? And once it is approved by insurance, do you think it will be like a preventative test where it's like free under insurance, or do you still think it will be like a copay?
So let me repeat Millie's question. What she asked was, how far away do we think insurance coverage is for the test, given that it's out of pocket right now? I think they are incentivized. If you think about just the economics of it, it is in their interest to cover this in the future. But I think there is still a lack of evidence, and that's why they are dragging their feet, especially with the CCTA being also introduced into the picture. I don't know if Dr. Hoffman has a better answer, but I feel like I hope it happens in the next 10 years is what I'll say, but I think it is in their interest to transition and start doing this as a preventive test.
One comment on that. So that's been a huge, I'm catchy. Nice to meet you. It's a very frustrating topic. We've been dealing with this ever since I've been in training. It's a very cheap test, a very quick test compared to the other things we do for cardiovascular prevention or screening. It's dirt cheap. So we often fight with insurance companies and lobby for this. And the SCCT as an organization, the Society of Cardiovascular CT, has been lobbying for this for years. With the changes in the guidelines, as Shreyas mentioned, we hope that it comes down the pipeline. It's always delayed. Insurance companies are always behind, especially in America. But it is very cheap. It has a lot of potential to save costs for carriers. So we hope that in the next coming years, it does become affordable. Now, you're right that it is expensive, but what I would comment for your patients, for your family members across the country, even within one city, you can have 4 or 5 different centers that charge a different amount for these particular scans, as low as $80, as much as $300. It all depends on the different setup for the different hospital. So as a provider in different cities, I just found out those resources and said, look, here are the ones that are the cheapest. If you're really on the fence about the statin, then maybe you should consider this as an investment, as a test. To your point, very good point about the multivariable analysis. We don't just use this as a one-dimensional parameter. There are studies looking at diabetic patients where you have a CT as a initial strategy to risk stratify, looking beyond just the calcium score and looking at 5 characteristics. And there's no difference in outcomes to make decisions based on a CCTA on the diabetic population, mostly because if you treat diabetics the way the guidelines suggest, you should already be on a statin, you should already be controlling blood pressure effectively, you should already be eating better and losing weight. So on a population that's aggressively risk modified, adding a CCTA or a coronary calcium score has not been shown to change outcomes. So the point about multivariable intervention is very, very key. I think that the coronary calcium score comes into play in a patient that's in an intermediate risk that just isn't sure about it, just on the fence, isn't committed to their lifestyle, diet, and medical prevention therapies.
Dr. Fraser.
So I have an ethics question, so we'll have questions for both of you, but to start with the ethics question, I mean, what's the evidence that you can actually teach people ethics and sort of moral behavior? I always think of that as something that's instilled in people from a very early age, from, how they were raised, family, behavior, religion. And so is there evidence that we actually could teach medical students ethics and that we would change their behavior?
Right. So I think Dr. Fraser's question was, can we actually teach ethics and can we actually teach moral reasoning development to medical students? Is there evidence for being able to teach these skills, or are they something that's just instilled and ingrained in people? So there have been studies, as many of you are well aware, medical education research at its peak essentially shows behavior changes in your student. And that's kind of like the ultimate proving that your intervention worked. Within the medical field, the ultimate proving that your medical education intervention worked is that there are patient outcome changes down the road. Those would be seeing like patient outcome changes or behavior changes, difficult to measure in this field. I will say that the studies that I've talked about looking at the other graduate students and PhD students in different fields, looking at progression in their DIT scores over their graduate training, I think is startling to see that graduate students are progressing in these areas versus medical students don't. They don't have any changes. Their scores actually regress. Whether this ultimately influences behavior or brings, changes to patient care, hard to say. That would be a very difficult study to perform. Finally, I think just from personal experience, at Medical College of Georgia, I was part of Leadership Through Ethics. We started a medical ethics certificate program there, just based on a very small Likert scale study of our intervention within the medical students. They felt like they found that their medical ethics understanding and their kind of framing of ethical problems improved by going through the program. But whether that actually influences behaviors and outcomes, difficult to say. Would need another more robust study. Does that answer your question, Dr. Fraser?
Anand?
Yeah, so thanks for the great talk. I was wondering, with coronary CTA becoming a more mature avenue of investigation, how do you see that additional data being used for this all-comers population? Because most of the data for coronary CTA seems to be in a stable angina, like people who already are being evaluated for invasive angiography versus non-invasive testing. So how do you see, like in the next 10, 15 years, I guess, how do you see coronary CTA being brought into the all-comers risk stratification?
So I feel like CTA is a different test because we can use it in patients with angina. It's not only a primary prevention tool like the CAC test. And I think the fact that we get the degree of stenosis, if it's a hard or a soft plaque. I think these are, and that's what the current debate is about, if we should bypass this test and essentially do a CCTA on patients if they have good kidneys. But it is a lot more radiation. It does have contrast. And that's why I think the debate is still running. I don't know if
You answered it really, really well. It's a very hot topic right now. Everyone's talking about it, especially with the newest scanners. The photon counting scanner that we have in the North Campus used for the PET cases will take as little as 5 cc's of contrast and as little as half a millisievert. So once that scanner becomes mainstream for not just the cardiac patients, but for all CT scanning patients, it's going to be a huge, a very attractive alternative for cardiac imaging. Not only is it better temporal resolution, better spatial resolution, and you can add on all those extra features, apply characteristics that are stratified. Having said that, the Miami Heart study that was just published last year with Coronary out in Miami and Florida and Houston. Also in Sweden, there was a trial looking at asymptomatic patients with CCTA as an upfront strategy. The next step after Scott Hart showed that there was an outcomes benefit of using CCTA as an upfront strategy for symptomatic patients. So the question becomes, how much better is your negative predictive value if you add on the CCTA on top of a calcium score of 0? Calcium score of 0 patients in both studies had 16% prevalence of any plaque. Now, only 0.9% to 0.4% prevalence of stenosis greater than 50% in a CAC of 0. So you're talking about less than 1% incremental identification of what we might think of as a significant disease. So the question becomes, is it cost effective to add the CCTA? Is it better? Is it worth taking the risk of contrast reactions and extra radiation if you're only adding on a tiny amount of information that we still don't know is actionable to create outcomes differences? So all that's ongoing right now. Both studies that I just mentioned are only in their first year of publication of data. The 3 and 5 and 10-year outcomes are yet to be determined, but that's a really hot topic. And from an individual standpoint, I find it sometimes easier to order a CCTA than a calcium score. One, because in the right patient, if you write it the right way, and if you actually justify it the right way, insurance will cover it. And ironically, they won't cover a calcium score, which is the most frustrating thing in the world. So having said all of that, I'll also pitch that, we're talking about calcium scores and how incredible it is, but there were plenty of studies now, again and again, since I've been out of fellowship, looking at any scan in your system. How many patients do you come in confirmed or in your outpatient setting have a PE protocol CT in their history? Take the time to just open that study and scan through the coronaries. If it's sliced in the right way and to have enough calcium, you'll see it and you'll have your answer. And you can have that entire discussion that Shreyas described, and you have that benefit. And again, that's useful. And so whenever we present at firm or at the outpatient setting, we always look at the gold standard that's available.
There was a study, they looked at the low-dose chest CTs for lung cancer screening, and they showed that it was pretty much just as good. And
that's what this study showed too. We can use non-gated CTs, although it's not as accurate. They come up with something called the CAC DRS, which you can kind of extrapolate to an Agatston score and stratify them as low, very low, mildly increased, moderately increased risk, and can maybe allow us to escalate from there based on and many more radiologists are doing it, is what the current pattern suggests. They are commenting on it if there is calcium in the heart. And having a non-zero calcium is powerful. I think seeing that there is some calcium does allow us to make more nuanced decisions.
It's not just theoretical. This actually happens, with the current setup of clinic where the screen is right next to the patient. You just turn the screen and show them the calcium. You can see it in their face, their resistance knows, yeah, I do need to do more than I'm doing now. Now, it doesn't mean that, it's not necessarily just statins, but it's everything. It's blood pressure control, insulin compliance, and statins. It's very, very.
Wasn't there that data out of Scotland, I think, where basically they just got a CAC score and their risk went down, like their event rates went down without any intervention, just because, and they extrapolated that it was because patients were actually able to visibly see that they had heart disease, and they changed the stuff.
I'll step in if I may. I mean, the systematic review, there's been more than 40 trials of different types of risk stratification, actually has a very modest effect. So I think doctors, you all are doing risk stratification all the time anyway. And while we think that patients are changing their minds, the data suggests that it's only a mild increase in the initiation and intensification of pharmacotherapy and subsequent changes in risk factors. There's no data that risk scores change clinical outcomes. I wish there were, just not.
the trial you're referring to is Scott Hart, and it wasn't just a calcium score, it was a CCTA. And it was published in New England Journal in 2018. It was one of the first trials to show an outcomes difference. And you're right, there wasn't more PCI, there wasn't more anything other than more adherence to medical therapy. So the conclusion from that trial is that the outcomes diverged presumably from increased adherence to aspirin, statins, and other therapies. And the reason why we don't see it in other trials, like the diabetic trial that I mentioned, is because they're already adherent to those medicines from a prevention standpoint.
So these are great discussions that we can continue kind of offline if that's all right. So anyone who needs to head out, feel free, and then we can take other questions in just a moment. Thank you, everybody.
Jerry?
You both did great.
Thank you.
Really wonderful.
Oh, thank you.
I'm really
Appreciate
proud
it.
of both of you. Thank you so
Wonderful.
much.
Thank you.
Thank you, appreciate it.